Hello people, here is Dr. Muskaan this side, and today I'm going to discuss very beautiful case with you, and I'm going to discuss ABCDEU criteria of CKD in this case with you. So let me take you towards the practical aspect. Here is 58-year-old female who has came to ER at 12:55 p.m. with chief complaints of fever with chills since 10 days, shortness of breath since 10 days, and burning micturition since 10 days. On arrival, ABCS was done, that is airway, breathing, circulation, and sensorium. Airway was patent. There was no sign of airway obstruction on breathing assessment. Respiratory rate was 18 per minute and SpO2 was 95% on room air. That means there was no tachypnea, bradypnea, or desaturation. On circulation assessment, pulse rate was 90 per minute. That is, it is normal because normal range lies between 60 to 100 per minute. Blood pressure was 174 by 106 mmHg. That means it shows she is hypertensive. Sensorium was alert. GCS was 15 by 15. E4, V5, M6. That means eye was opening spontaneously. Verbal response was oriented, and on motor responses she was obeying commands. HOPI patient was apparently asymptomatic 10 days back when he developed fever which was intermittent in character, progressive in nature, associated with generalized body ache and weakness. It was relieved on taking medications. She also complained of shortness of breath, which was insidious on onset, progressive in nature, and med score was 4/4. Patient also, what is med score 4/4? That means patient was feeling breathlessness even on thinking that she has to go outside the house on during bathing, wearing clothes. Patient, that means it is on very severe side. Patient also complained of burning micturition, which was associated with urgency, incontinence after every 3 to 4 hours per day. It was not foul smelling, and it was associated with loose stools, which was 6 to 8 episodes. There was negative history of hematuria, vomiting, and pain in abdomen. Past history: she is known case of hypertension since 7 to 8 years on medications, that is tablet Amlong and tablet telmisartan. There was no other comorbidities. There was no surgical history. Past surgical history. Family history is non-significant. Personal history: she is vegetarian by diet. Sleep habits were adequate. There was no addiction. Bowel habits: she was showing loose motion, and bladder habits: there was burning micturition. General examination: patient was lying uncomfortable on bed due to hemodialysis catheter insertion. She was again saying that, oh, I am not feeling comfortable with this, please remove it, please remove it. So yeah, she was feeling uncomfortable. And vitals: there was hypertension, rest were normal, and in pickle there was severe parallel, icterus clubbing, cyanosis, edema, and lymphnopathy were absent. Investigation pictures: CBC shows severe anemia because hemoglobin was 7.9 gram per dl. Platelets was 1,24,000, which was also less, showing thrombocytopenia because normal range is 1.5k, 1.5 lakh to 4 lakh. KFT picture shows increased urea. It was 183 mg per dl. Increased creat, that was 10 mg per dl. Increase in uric acid, that was 7.8 mg per dl. There was hyponatremia, and GFR was 4 ml per kg per minute. That shows stage 5 kidney disease. LFT picture shows increase in alkaline phosphatase level. That was, rest was normal. ECG picture shows left ventricular hypertrophy. Dengue, NS1 antigen, IgM, IgG test was negative. Typhoid, IgG, IgM test was negative. Malaria test was negative. Urine culture and sensitivity shows no growth. ESR was increased, that was 110 mm. Normal ESR lies less than 20. And raised ESR, what is the mnemonic for raised ESR? That is napkin. And N stands for neoplasia, A stands for anemia, pregnancy, kidney disease, infection, inflammation, and neoplasm. So what is the reason of raised ESR in this patient? That is anemia and kidney disease. Peripheral blood picture shows microcytic anemia with neutrophilic leukocytosis. Iron profile shows iron deficiency anemia. Vitamin B12 profile was normal. Echo report shows normal LV systolic function. Concentric LVH, that is left ventricular hypertrophy. Mild MR and mild ER, that is mitral regurgitation and tricuspid regurgitation. HBS, AG, HIV-1-2, HCV test were non-reactive. Ultrasound whole abdomen report shows left renal cortical cyst, mild bilateral pleural effusion, by increased bilateral cortical and medullary renal echogenicity. Then I applied Cockcroft Gold formula, that is creatinine clearance formula, that is 140 minus age into body weight divided by serum creatinine into 72 multiplied by 0.85, and through this formula I calculated the creatinine clearance, which was 6.16 ml per minute, which shows stage 5 kidney disease. So yeah, management of this patient, injection monosef was given, which was a treatment for bacterial infection. Injection levoflox was given, which is antibiotic. Injection lasix is given, which is diuretic, furosemide, okay, acting on leukophilin in nephrons. Injection amlong, which is a treatment for hypertension. Injection capsule Difilac is given, which is treatment of diarrhea. Syrup alkazole is given, which is to treat UTI. Injection MCED is given for vomiting. Tablet Fivixostat is given to treat hyperuricemia. Tablet Rezody is given, which is to treat GERD, which is a proton pump inhibitor. Tablet Shelcal is given, which is calcium and vitamin D3 combination. Sacket Uprise is given, which is vitamin D3 deficiency to treat, which has vitamin D to treat the vitamin D deficiency, and especially to treat osteoporosis. Tablet injection mole is given for fever. Injection perinom is given for vomiting. So the diagnosis of this case is acute on chronic kidney disease with anemia and with hypertension. And I want to discuss A, B, C, D, E, U criteria of CKD. A stands for anemia present in our patient. B stands for bone mineral disease present in our patient. We are giving Uprise Sacket and Shelcal tablet supporting vitamin D3 and calcium to the patient. Why? Because she is weak. Cardiac complications present in the patient. I told you about echo report and ECG. Diuretic use, yes, it is there. Lasix we are using. Electrolyte disturbance is there. Hyponatremia is there, and uric symptoms is also there. CKD patient, why uric symptoms will not be there? So yeah, it was an interesting case. I really enjoyed this case, and at the last I want to give one good question to you to study, that just study how anemia affects CKD patient and how it leads to further LVH and everything. So yeah, that's all. Dr. Muskaan Bansal is signing off now.